My name's Adrian Boyle. I am recording this talk in Cambridge, England, and it's a great privilege and honour to come and speak to the Swedish Society for Emergency Medicine. I'm going to be talking to you about emergency department crowding, and I'm going to try and start a screen share now. This is my first slide, and this should include my Twitter handle and the hashtag which I use when I talk about crowding, which is hashtag crowding kills, because I passionately believe crowding in emergency departments is one of the greatest problems facing healthcare. So I do have some conflicts of interest that I need to declare. The first is that I have my own IT company which produces analytical software to try and understand the causes of crowding. Doesn't make any money, but it's still there. I'm also supported by a number of research organisations, the Health Foundation and Cambridge University Health Partners, and the Small Business Research and Innovation Fund. I don't think this will change anything that I would say to you today. So this is a photo that I use, and hopefully if you're an emergency physician, you'll have an appreciation and a feeling of what I might understand like. This photo was taken in an American hospital, but I think this could be seen in most emergency departments around the world. And my heart really goes out to that nurse standing in the middle, because I think we've all been there, where we look at that and go, what do I do next? This feeling of slight helplessness when you are so overwhelmed with patients just stacked up in corridors. And I would say that we are all experts in crowding by lived experience. I understand Sweden is a little bit late to the party, but you're catching up fast. So crowding in emergency departments is what is best phrased a wicked problem. And a wicked problem are difficult to define. And we'll talk about the definition of crowding. And there's lots and lots of things which go on and cause it. And if you try and fix it with one problem, you often lead to unforeseen consequences. And it's often not stable. So sometimes you'll have times where you're not crowded, and then you'll have times where you're crowded again. And the solution is often not clear. And responsibility is divided among lots of people. And sometimes solutions involve changing behaviour, either from the public or from doctors within hospitals, or even sometimes emergency physicians, and is often the result by a result of chronic policy failure. And I think crowding in emergency departments ticks all of these boxes. So crowding is important. And one of the things I sometimes struggle with is to explain why crowding in an emergency department is important to doctors working outside emergency departments. They'll say, oh, you're just being busy. You've just got too many patients who shouldn't be there. They're all drunk. They're all mad. Just send them all home. Stop bothering me. But I think crowding really matters. And there's a number of systematic reviews. The most recent is by this New Zealand group led by Claire Morley. These are the problems that come from crowding. There is a failure to identify a deteriorating patient. Usual medications get missed, particularly for diseases like Parkinson's and diabetes, and this makes matters worse for the patients. And, sometimes patients will develop pressure sores if they're waiting for hours and hours in your emergency department. But does it really matter in terms of whether it kills people? Well, I think I can show you some of the evidence behind this. It also matters because if your department is full, you can't offload ambulances. We call it handover. Offloads is another term. And that creates two problems. You've got a problem for the patient who's in the ambulance outside your emergency department who is not getting the care that they need. But also, that ambulance can't go to the next patient. And that delays treatment for a cardiac arrest, treatment for a road accident, treatment for a stroke. There's well-described delays with treatments for analgesia, antibiotics, for sepsis, and recognition of serious illness. So crowding is important. In terms of the actual mortality data, there are about 10 studies out there that were cited in the Morley paper, I'm aware that there's another paper going through peer review from this country. They all tend to be low quality. And the great limitation of all of these studies is they do not adjust for either illness severity or the age of the patient, or if they arrived by ambulance. Of what we found, but 3 found no association between occupancy levels, but were only looking at condition-specific mortality. Now, as an emergency physician, I actually think we're quite good at looking after the person who turns up with a STEMI. We're a little bit better at someone who turns up with sepsis, but the hardest part of our job is the patient where nobody's quite clear what's going on with them. They've been found unconscious, they're lying on the floor for a long time, where there's a very broad differential diagnosis with lots of potential causes. 7 studies found that increased crowding in an emergency department was independently associated with increased all-cause mortality. It's not a strong association, but it's definitely there, and it's definitely a plausible association. To my mind, these are the patient groups who are most harmed by crowding. The frail elderly, the patients who have significant care needs, and particularly nursing needs, whether they need to be on a trolley, whether they've got multiple medications, are particularly disadvantaged by crowding. If you're 80 and you turn up to a British hospital, you have an 80% chance of admission. And crowding is usually caused by lack of beds to admit a patient in. Patients who suffer mental health crises are particularly ill-served. Now, I can work in my emergency department and not get too frazzled and too mentally ill for 12 hours. That's a normal shift length. Imagine if you're in a state of heightened anxiety or paranoia and you go to an emergency department where no one is available to look after you properly. There are lots of other agitated patients. It's noisy, it's distracting, and no one has the time to tell you what's going on. That will make matters worse for you. There are well-described delays to analgesia for children. When you're busy, it's that much harder for the nurse to go to the drug cupboard to get the analgesic, the painkillers for the kid. And no one likes the idea of kids in pain waiting because people are too busy. And then finally, medication errors go up when people are busy, because when people are busy, they cut corners and people will make medication errors. There is also a phenomenon when emergency departments get crowded, they admit more people, and they admit people who they might have otherwise sent home. This is known as the bullwhip phenomenon. A small deterioration in performance within, say, primary care, within clinics, has a bigger effect on the emergency department, and that in turn has a bigger effect on the inpatient hospital. Crowding is also a miserable place to work. Working in an emergency department that is crowded, consistently crowded, makes bad doctors out of good doctors. Your decision-making is rushed, your professional satisfaction is reduced, and it becomes an unpleasant and toxic working environment. So I think I've made the case why crowding is a problem. The question is, what are you going to do about it? And within a sort of engineering mindset, which is where most of my university collaborations have been with, is thinking, okay, how do we break this problem down and try and deal with this wicked problem? Now, when you fall off a motorbike, and I have a bike, your initial response is very much like the guy over here on the right. But actually, if you are being analytical about it, you want to actually try and understand and put some numbers to why you're crowded. And I think if you were to look at interventions, we need to try and break it down, because people will believe that crowding is not their problem. And I'm going to try and show you how you make crowding everyone's problem. So the simple model of emergency department crowding starts off with input, that's the number of patients coming in, throughput, and output. And we get crowded very simply in a number where we fail to manage the surge, where our processing through an emergency department is suboptimal, or because there are no beds to admit people to, or we can't get people home. So very simply, that is, the framework which I try and build all my crowding studies on. So measuring crowding is complicated and it's really difficult. And ideally, an ideal crowding measure would be something that's automated, so you don't have people wandering around with clipboards and managers creating databases. It would emphasize effort and attention on the most seriously ill and injured, because those are the patients we need to worry about the most. It would be clinically sensible to emergency medicine doctors and also to our inpatient colleagues, because without our inpatient colleagues, we can't fix crowding. And then finally, it would be operationally sensible to our managers. Unfortunately, it doesn't exist. So when I talk about crowding measures, I think the first thing to do is try and break it down into two types. There's nearly hundreds of crowding measures out in the literature. And very briefly, either they're a single measure or they're a bunch of measures together. Crowding measures really come into two. One, are they a flow item? That is there an element of time attached to it? Or is it a count item? Some people call the count non-flow, where it's just a proportion or a number. So to give you an example of flow items, length of stay. How many minutes did that patient spend in your emergency department? In England, we use the 4-hour target, the time to triage, time to admission, the time that somebody has to decision to admit. Count items are things like occupancy, a proportion of people who leave without being seen, and the total number of patients in your apartment who are ready to move on. And then there are these research scales. NEDOX by my colleague Steve Weiss at Phoenix in Arizona is the American version. It's probably the most established, it's the most validated. It's quite complicated, but it's well understood. And it stands for the National Emergency Department Overcrowding Score. The Edwin is the Emergency Department Work Index. Mine is the ICMED, and I'm aware that there were people in the audience who've generated their own scale for a PhD I'm examining towards the end of the month, called the SEAL. That's your Swedish one, and obviously for the audience I'm speaking to, it's the best one. So the ICMED and NEDOX have a lot of overlap. The ICMED, which is mine, the International Crowding Measure for Emergency Departments, was designed through a consensus-based process. It has 8 items which match quite neatly to input, throughput, and output. The NEDOX also has this, but has complicated statistics about it. And sometimes I think some of these are hard to measure, particularly if you don't automate the number of people who are on ventilators in your emergency department. But it's a good recognition that with that item, that second item, the number of ventilators in use in the emergency department, that ventilated critical illness patients take up an inordinate amount of effort and nursing time. This is the work from Jens Retborn and Ulf Ekelund, who invited me to speak here today. It's a good paper. But here's the paradox about all of these scales. So the scales which are around where people have actually applied a logical model of derivation and validation and are methodologically much better than the other measures are not the ones that report harms or the effective interventions in emergency department crowding. None of the papers, almost none, reporting harms or effective interventions of emergency department crowding papers use any of these scales. If this was hypertension, which we all know has got clear definitions, which are worldwide accepted, which allows easy comparison, it would be, and every country and every hospital had its own different way of measuring it, it would be regarded as a disgrace. Can you imagine? On today's definition of hypertension, I would classify you as hypertensive. We can't compare your value to anyone else. We don't know the long-term consequences of this value, and we don't know if any of the drugs work. Sorry. So I'm all trying for standardization of the way that we measure crowding. The next stage, once we have got a unified definition of crowding, I think the next stage that is coming is people are going to start, and this is my own research, people are going to start applying machine learning to crowding measures. And what these are going to be able to do is predict where you get busy, what your demand is likely to be by looking at previous states. And I think this is actually closer than it sounds. I know that I've put up a futuristic picture of the iRobot, but I think this is something that's going to come quite in the next couple of years, where on the top of your electronic patient record, it'll tell you how many beds you're going to need today and how many of them will be for women and how many will be for men and what time you need them by. And that should lead to smarter bed planning. There is a paradox and a problem about measures becoming targets. And there is this phenomenon known as Goodhart's law. When a measure becomes a target, it ceases to be a good measure. And we have seen it in the United Kingdom, where for years and years and years, we've had the 4-hour target. No one was allowed to spend more than 4 hours in an emergency department. They either had to go home or they had to be admitted. And it changed people's behaviors. And sometimes it was good, so they invested in more staff, but sometimes it was bad. They would invite more patients who were less ill to come to the hospital because they knew that you could usually achieve your 4-hour target for discharged patients. So the other things we found out about crowding over the time, it rarely occurs in your whole emergency department all at the same time. Now, there will be times where that happens, but it's not unusual. And actually, most emergency departments are best thought of as a series of separate queues. And most emergency departments have at least 4 different environments, which all have different queues: pediatrics, your resuscitation room, your majors, and your minor injuries units. And so if you think about a normal process of triage, clinician, investigation results, and admissions, that's not a linear process, and it's a process which is divided to those. So already you've got 16 different queues. So understanding this and teasing this out is quite complicated. But what do you want to do about it? Because emergency physicians largely want to fix things. You don't want to work in a crowded emergency department, you want to fix it. So, and the people who are in this audience are problem solvers. If you don't spend time working in an emergency department without getting good at solving problems. Some of the first question I would ask when you're trying to do it is to ask, who's responsible for ED crowding? And it's a great place to start with by asking who's responsible. Now, actually, lots of people are responsible, even though they don't think they are. What you also probably want to get away from is it's not always the emergency physician who's responsible. So you go and see your hospital chief executive or your chief operating officer. He may have an office like this. I can tell you for free, my office does not look like this, and I doubt anyone in this room has an office that looks like that. This is one of my favorite papers, and I think there's nothing worse than when people just put up loads and loads of papers, but this is one of my favorite papers because this is a qualitative study looking at the characteristics of the hospitals that were good at managing crowding in North America and those that weren't. And they did interviews with people, and they looked at people who were, they did all sorts of interviews, all sorts of general things about 4 high-performing, 4 low-performing hospitals. And what they found was that actually it's quite simple. Hospitals that do well on an emergency department have the 4 following characteristics. First, the executive team are involved. So your chief executive or your chief operating officer or your director of operations, your senior managers know what's going on and they care. Secondly, it's about having data-driven management. Have a report every day that shows what happened in your department. Thirdly, it's got to be across the whole hospital, hospital-wide coordinated strategies. And then finally, people are responsible and accountable for their bits. So when I think about who's responsible, going back to my input, throughput, output graphic, I think the ambulance service have responsibilities. Now, in the UK, our ambulance services, on average, transfer only half of the people that they're called to go and see. But this number varies widely. And if it varies from 20 to 60%, I want to know what's happening with the people who are outlying. Are there ways that the people who are the ambulance services who are bringing too many people could actually do better treatment? Could they do treatment at home, which meant that a patient could stay there? The relationship between primary care, that is your general practitioners, and your emergency department can sometimes be a little bit fraught. It can sometimes be difficult, but it's worth making sure that there is sufficient access. And you can probably identify when your GPs aren't at work, suddenly your emergency department feels busier. And you need to compliment your GPs for taking work, preventing lots of patients coming to you. In terms of throughput, that's us. We're responsible for throughput. We need to make decisions promptly. We need to engage with our radiologists and our laboratories so we get quick responses on our diagnostics, and we need to engage our other specialties to provide rapid consults and make decisions as well. And then finally, with output, this is the people who are responsible for this are our managers and the number of beds that your hospital has. So having decided who's responsible and indicating that some of it's ours, if you're running a department, you need to know your data. This is a Sankey chart, and it shows the flow of people going through my emergency department. I did it on Sankey-matic one boring Sunday afternoon, which you need to know your data so you can go and show your managers what your problems are. And in the UK, the big patient group we're really struggling with at the moment are the ambulant majors patients. So there are lots of interventions that you can do. Not all of them will apply to every hospital. As part of for the Royal College of Emergency Medicine, I produced this document. It's called Tackling Emergency Public Crowding, and we've ranked all the interventions that you could do and who should take action. In most hospitals and in most care systems, the big problem is the output, the beds and the moving patients through the emergency department, exit block. So if you're running a really efficient emergency department, you've probably got these four things working well. You've got enough space and cubicle space to see your patients. You've got enough staff. You've got good processes that everyone agrees and follows every time. And at the end of it, you've got a bed to put the patient in. Those are the four things you need to look at. We make recommendations. So now, in the UK, a commissioner is someone who is a manager who pays for hospital services. And sometimes you say, well, you're not giving us enough money to do this piece of work, or you need to make sure that this other service, which will see patients who don't need to be there, is also available. So our guideline here has a bunch of recommendations which are aimed at each person. Within this, there is a controversial, and I couldn't help put in the most controversial bit of this guideline about boarding. So this is where a patient, when it is decided that they need to be admitted in a hospital from the emergency department, they go directly to the ward that they're supposed to wait on. They go directly to their destination ward, regardless of whether the bed is available. And if that means they have to wait in the corridor of that ward, then so be it. Because what that does is it actually makes the wards go, I need to get these patients out. There's a patient coming to me. I need to get my other patients who are ready to get out. In some UK hospitals, the average time of discharge from an inpatient ward is 7 o'clock in the evening. Now, in my department, I need beds from 11 o'clock in the morning. And that mismatch of 8 hours leads to huge amounts of crowding. Now, this has minimal effect on the numbers of admissions, but it stimulates whole hospital ownership of the ED crowding problem. And you also get the right patient to the right ward. You want to minimize the amount of ward moves that a patient undergoes. It stimulates wards to improve discharge processes, and it spreads risk across the whole hospital than concentrating and multiplying risks in the emergency department. There is a little bit of evidence. My friend Peter Bocelio has written about this in his hospital in Stony Brook in New York. It's not necessarily a popular thing to do. The wards that receive these patients have to have enough staff, they have to have sufficient space, and it shouldn't be just seen as moving one patient, just shifting the problem upstairs. Corridor care is bad wherever it happens, whether it's in the emergency department or in inpatient wards, and it can be potentially toxic. I put up a picture of Britney Spears because she did a really good song called Toxic. So I talked a little bit about what you as emergency physicians can do. You need to leverage your managers, you need to engage your inpatient teams to help you. But I just thought it might be useful to say what our Royal College does in terms of advocacy. Now, the Royal College is not a statutory body. We don't make laws, we don't fund hospitals, but what we do is point out where we think we offer guidance about what should happen in our emergency departments. Our mission is to improve care in the emergency departments. And we have a program, a campaign that we run every year called CARES. Top of our care, and these are the top 5 things that we need to happen to improve care in emergency departments. And number 1 always is we need to be less crowded. So our RChem CARES document has lots and lots of suggestions about how to improve care in emergency departments. 1 is reducing crowding. 2 is making alternative access for patients so they don't all need to come into hospital. We have a problem in the UK that staff get burnt out and leave. So we want better terms and conditions and better working environment, so about retention. We think the patient experience in crowded emergency departments is poor, so we actually want to try and improve that. And finally, we want our departments to be safe so patients aren't harmed. This may be something that the Swedish Society might want to consider, but if you are going to do this, it is probably worth talking to us because it can be a potentially high profile and risky thing to do. Thank you very much for listening. I hope there have been some questions put into the chat, and I'm hopefully I've generated a bit of a debate. I'm only sorry that I can't be in Sweden with you. Thank you.